For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 3, Episode 49 of Surfing the NASH Tsunami. Our look at the recent NICE meeting on use of VCTE in community settings in the UK starts now.
This week on Surfing the NASH Tsunami.
We've got a number of challenges. One is to persuade society that liver disease is important, not only through cancer. We have to show them ways that it can be made better, whether that's with public health interventions, with medicines, or with lifestyle advice. And then we have to make testing easier so that those interventions can be delivered in a way that's meaningful to patients.
When we're scanning people, we're definitely finding a good number of people with cirrhosis who were previously undiagnosed and had no idea. This really highlights the importance of an early screening pathway.
It's come back out of purely being let's work out the cost per test to now being maybe we have to go back and look at the whole pathway as to how you get the test.
Unfortunately, your liver disease is worse the further down the socioeconomic strata you go, and the more marginalised you are, the more likely you are to run into bad outcomes from liver disease.
That was one of the best debuts we've had in the history of this podcast. Yeah, that was spiky, that was different, nobody had said that, and it all makes sense.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guests, hepatology researchers and key opinion leaders Professors William Alazawi and Ian Rowe, and health sciences researcher and nursing key opinion leader Kathryn Jack, as they discuss the recent NICE meeting, taking a second look at the economics of FibroScan use in community settings in the UK. This week on Surfing the NASH Tsunami.
Hi, it's Roger. For reasons that I don't understand, Will Alazawi's recording on this episode was unable to transmit clearly. In fact, 3 days after we recorded the episode, only 80% of it had come through, meaning he must have had the slowest line we've ever seen in 150 episodes. At any rate, some of his contributions were choppy, and we had to make the decision whether to eliminate Will's contribution entirely or whether to live with the choppiness and ask you guys to forgive us. I went for Plan B, so please forgive us for choppiness. I promise we will have Will on again. He's been a fascinating guest, and we will have his audio clear and clean as a whistle next time he shows up. Enjoy the episode. So we've been blessed with technological challenges today, as we are sometimes. Jorn is getting on a flight, and one of the guests who was supposed to join us sent a note an hour ago asking if we were still doing the podcast, which suggested that he never got his link. So we will be four of us, and we will be hardy, and we will be fierce, and we will be fabulous. Of course, we have the always hardy and fierce and fabulous Louise Campbell. Louise, how are you doing this evening?
I'm doing well, thank you very much. Having had a nice weekend, doing the spring cleaning in autumn.
You know, it's funny you say that because I did the same thing. We obviously were kindreds on this. Mine includes window washing, hanging out over a ledge. So it's
becoming spooky, Roger.
Yeah, it is. It's entirely too much of that. Soon you'll be rooting for Tottenham, and then we'll know that we've totally converted you.
It's not that spooky.
And then Ian Rowe is with us. Ian, how are you?
I'm very good, thank you. As coincidence would have it, we spent most of the weekend cleaning the house as well, so I'm slightly concerned about what this means for all of us, but hopefully we'll survive it.
Well, and Ian and I both had good football victories to celebrate over the weekend. Louise's teams went 1-1. The one she likes best, though, is the one that did least. And then we have Kate Jack. Kate, how are you this evening?
I'm very well, thank you. It's great to be here and to be able to chat with you all again. And I didn't spend the weekend cleaning, so I'm the odd one out.
So let us be jealous. What did you do this weekend that was more fun since you weren't cleaning?
I don't really know. I had a really long lie-in because I was tired on Saturday morning, and I don't think I did much else apart from that. So.
Well, good for you.
I want to find out about Will. I want to know
that's
Will's...
right. We did not do Will yet. Good.
Yes,
go ahead.
Yes, you did not do Will.
Thank you, Louise.
Will, as Roger is already summing up different things, we normally start with an introduction, a couple of minutes about yourself, and then the bit that we rank is tell us something that most people wouldn't know about you. Now, we've had Racing with the Bulls in Pampeloma with Jeff Lazarus, Kill Surprise, to all sorts of things, but go on.
After you're done, we'll tell you what we think the winner is.
Summary.
The best efforts, and there are a couple that are amazing, but go ahead.
One includes Gold Glame, and I'm still seeing it.
A little about your work first, Will, so that people outside the UK who make about 80% of listeners podcast 85 have a sense of where you come from and what you do. Okay.
Sure. So I'm William Alazawi. I'm a liver doctor. I'm a consultant hepatologist, professor of hep, that into ways in which we look after patients with liver disease. And that's through actually speaking to colleagues, speaking to patients, and doing events like this and sort of making sure that the conversation is alive where we go. I'm also involved in a number of the treatment trials that are developing, as Ian is himself. So, of course, now you've got me, the blood pressure's going, the adrenals are in spasm. What am I going to say? What's going to be interesting? Totally boring. I like reading history books. Actually, that is true. But what I am going to tell you is not about me. It's about the cacophony that you can hear downstairs, which is that although I can't play a tape recorder, I'm very fortunate enough to live with two wonderful children my children, definitely much more fun than I am. So do you
conduct?
I get conducted.
Yeah, well, that's parentage. That's being a parent. We all know how that works. So that's pretty good. Louise's winner, I think, is Neil Henderson dancing in gold lame pants, and my winner is Mazen Noureddin playing pro basketball in Syria. And we've had some others that are pretty spectacular. And if Mazen were 6'4", we'd probably have somebody else would be my favorite choice. But thank you for that, Will. So what we're going to do today is, if you remember back in March, we did an episode with, I think Ian was on that one also, and other cast characters, after NICE had taken its first look at VCTE. And during the comments period, we had Chris Estes with us, I believe, who was able to talk about some of the forecasting issues related to that. And it was a fantastically interesting conversation, and everything that goes around comes around. It's 7 months later. There's been the second meeting, and we want to go through the general subject of what came out of that meeting, and in the process, what we're learning about ways to think about the use of VCTE and more generally, the application of guidelines. I should tell you that on a related subject, I guess, we're dropping our final episode of Rising Tide, of the 4-episode Rising Tide in Diabetes series tonight. And that episode is somewhat tangentially related to this, in that Mike Patel, who is the head of the Fatty Liver Alliance, the Canadian patient advocacy organization, decided to help educate Canadians with NAFLD and NASH about the process that he was going to have his own liver evaluated. But he didn't follow a guideline. He just did not every test in captivity, but 6 or 7 of them, literally, and got very, very confounding results. So the best case I've ever seen for clarity of guidelines was watching the path that Mike trod from pillar to post, hither, yon, and then all that about 7 times in the process of sorting out what was going on. And if you want to come to the website and listen, it's episode 4 in the Rising Tide in Diabetes series, and it's a great listen, so enjoy it. With that, why don't we get started? I think we're going to have to professional icebreakers because we've already talked about everybody cleaning over the weekend. So one good piece of professional news from the last week. Brave one, go first.
I'll jump in. I'm going to sneak an extra couple of weeks back because we hosted the British Liver Meeting in Leeds for the first time in my memory, at least, which unfortunately now goes back nearly 20 years of UK liver meetings. And it was fantastic, brilliantly organised by the committee. Played a very small part in that, but colleagues did a great deal more work. And it was wonderful to get everybody back together again. It was the first face-to-face UK meeting we'd had since the pandemic, and it was absolutely brilliant. Really well attended, lots of great feedback, and lots to look forward to in the next year.
That's fantastic. Top that, somebody.
Oh, I'll jump in next. Well, my professional is obviously app is launching, and it should be released this week, which is great. We keep getting slight delays, but that's not uncommon with any app sort of launches, is my understanding. And for Ian and Kathryn, who probably haven't listened to last week's episode, we've launched the first lifestyle app that just tracks your health. You get to track your own health your own way, keep it simple, traffic light system, but it also allows you to subscribe to FibroScans if you want to do that. So it is not a healthcare app, it is more of a lifestyle, and choosing to look at liver health as part of your trajectory in changing your lifestyle management. So again, we're close to breaking new barriers. So that again is my professional, because I'm now about to take a holiday and play some golf and hopefully get my handicap down, which will be my personal aim for the next couple of weeks.
Okay. And Kate? Professional good news in the last week?
Professional good news this week. I was very recently in Geneva with some other colleagues from the EASL Nurses and AHP's task force, and we had a really successful planning meeting discussing the nurse and AHP involvement in the upcoming International Liver Conference that'll be in Vienna on next occasion. One of the areas that we were discussing was how the interprofessional contribution might look like for subjects such as NASH and NAFLD, because all the input that dietitians can bring and physios with exercise, and we'd be looking forward to contributing in the way that we can.
I guess my good news, first of all, is we had the largest single download day in the history of the podcast on Saturday. As recently as, say, 18 months ago, it would have been a huge week if we got 1,000 downloads. And for the first time ever in the history of this podcast, we actually broke 1,000 in a day on Saturday, 1,028 to be exact.
Annie Rees, that's really excellent news.
Well, you know what? A lot of interest around the last episode. Episodes that do best on this podcast tend to be news stories, convention coverage, breakthrough issues. And the episode we did last week, which was the review of 5 recent press releases. For those who've not listened yet, I think you want to go back and catch this. Akero, Altimmune, Poxel, Excella, and then Intercept withdrawing cirrhosis is, I think, Louise is going to wind up by the time we get to the end of tomorrow as one of our top 6 or 7 all-time 7-day downloads. But the other thing that happens is when people find this podcast for the first time, they've been known to go back and download 100 episodes at a shot, and we had a few people do that. So those two factors together, huge day. It also means that when I said last week that sometime in the middle of the month we'll go over 100,000 downloads, that's probably going to happen sometime this week. In fact, it might happen between when I'm speaking now and when we actually go live at 10 o'clock Wednesday night. We will be throwing a party for ourselves in our episode. The record's on Halloween and drops on November 2nd to celebrate the event. I'll give you a little more about that as we go forward. So that's the podcast story. Oh, that, and then we signed a new client last week. So I can't announce who that is yet but they'll be with us as part of our coverage for AASLD. So with that, this is really, I think, Louise's topic more than mine. In fact, Louise is going to be doing the intros and exits on the conversations later this week instead of me also. So with all that in mind, why don't you kind of dive in for us, Louise? Your floor.
Thank you. And this really is carrying on the debate, specifically in relation to the NICE technology or the MedTech guidance considering access of FibroScan for primary care. And I think it's been an interesting experience. It's probably around about 9 months in progress so far. And this was the second public meeting. It's like a wheel. And I'm sure Ian and Kate have sat on NICE or advised and acted in various different guises. My previous experience has been for hepatitis C and on patient advocacy in the Royal College of Nursing side. So when you sit in the room and have those conversations, it's sometimes easier face to face. This is obviously now a Zoom experience with even the committee members not in the same room. So it's an interesting experience. You get on, you sign off your name, so you're just a public observer, and anybody can register to be a public observer. So what we're discussing today is not confidential information anymore. But what is interesting is we do seem to have come around to one of the initial points. It was very much a focus, and I think you stated this before, that NICE are very, very particular about what they review, and they set particular black and white lines around it. This is certainly, from watching and being part of those processes, something that doesn't quite fit in that box. And I think that's part of where FibroScan sits traditionally. It's got scan in the title, so most people think it's radiology delivered. And in fact, the original presentation was done by 2 radiologists, which was then retaken back to some extent because a lot of the information was incorrect. A lot of the premise that 100 people would walk in the door and 100 people would walk out the door, and it was purely just a scan, seemed to surprise people. It became, during the middle of the process, about purely the cost of the scan. Is it cheaper in secondary care or primary care? Except we have now gone back to the very beginning to have it recognised that you cannot get a FibroScan either in primary care or in secondary care without a consultant appointment in most hospitals. So that was thrown back into the ring this week as a cost. Now that cost is over £200 in most areas. So what was looking to be break even, I should say, and in some respects more expensive in primary care, by adding back in the original costings to be able to get the test, has now made it more expensive by my calculations. So it's come back out of purely being let's work out the cost per test to now being maybe we have to go back and look at the whole pathway as to how you get the test. So I'm going to stop there because Ian obviously and Kate have comments on that, I'm fairly sure, is that this is unusual for NICE to be about to turn something down, which was the last meeting, and then to revisit it, and then to still have not necessarily looked at the right calculations. And after I've opened it up, then I'll make some more comments about what was generally discussed and the field. So Ian, you've been to NICE before, you've done that.
So, well, I've never been to NICE before, but I've read a lot of their documents in great detail and have provided, or as part of teams, evidence synthesis to support decisions that NICE make. I think you're right. This is a technology that is a little bit outside their usual wheelhouse. They think they struggle to understand its place in the diagnostic pathway. And I think to some extent that's because over the course of the last 5 years, the diagnostic pathway is shifting and has changed quite a lot. I think if we reflect on what we were doing in Leeds 5 years ago, FibroScan was a third-line test delivered in a small proportion of patients in secondary care after at least one consultant visit. Today, it's part of our primary care pathway. The test is still delivered by an employee of the secondary care trust, but certainly don't need to see a consultant to be able to have a scan. And I suspect the same is in Nottingham too, and has been for a lot longer than it has been in Leeds. And a lot of the evaluations of FibroScan and the source of evidence that NICE are looking for, they're just not there. That evidence isn't available. And when they ask questions about what is the cost effectiveness in FibroScan in primary care versus secondary care, there's still quite a lot of missing information for them to be able to make a decision. And I think it's that continued uncertainty and changing background that's making their decision making so difficult.
I'd just say as well, we've where I work in Nottingham, we've had a change to our FibroScan referral pathway a couple of years ago, and the consultants asked GPs to send a considerably larger number of people in with all kinds of risk factors. And we had a fairly large waiting list, which we're making really good inroads on. But when we're scanning people, we're definitely finding cirrhosis or fatty liver, definitely fatty liver, but a good number of people with cirrhosis who were previously undiagnosed and had no idea. This really highlights the importance of an early screening pathway, because once we found people who were quite unexpected and didn't realise that that's the conversation they were going to be having on that day, we can then deliver some very targeted brief interventions, give people quite a lot of help and support at the time, make sure they then get fed into the consultant clinic pathway, and we're picking them up early. So it feels for me that the concept of doing FibroScans early in the community is a bit of a no-brainer. It's very compelling.
Everybody sitting around, the experts, and obviously I provide expert opinion, but like every expert, have to declare any conflicts of interest for doing that. But we cannot sit on the committee. We're not involved in those. And I think you're right. It's a no-brainer. As Ian said, it doesn't fit what is normal. There is normally a lot of evidence that comes with any of the technology that they're reviewing. FibroScan only came into the UK in 2017. Much of the data that is being reviewed is out of date. We cannot use data that's not produced outside of the UK because it's NICE. However, a lot of the data being considered is not high in volume. It is very much specialist scanning service provided, often by the majority of units in the inpatient setting, even though that they are directly referred from primary care rather than in the primary care setting, with a few exceptions, but by the liver team. So that doesn't necessarily help the liver teams reduce resources or expertise. So that's right, it really doesn't. If you look at CAP, for instance, that wasn't even introduced until 2014. Most of the recent figures are badly affected by referrals. During a COVID period, there were no referrals in for most areas. People weren't even attending their GP. So when we talk about figures and saying minor figures can make a massive difference to the cost effectiveness of the case, when we're looking at COVID figures and not talking that they're COVID affected, it really has thrown a new dynamic, because actually COVID's not been mentioned once. Oh, it has been mentioned once on this recent meeting about how it did affect the referrals. So it has been an interesting concept. I think my general feel of this meeting the last time was it was very positive. The primary care physician really nailed it on the head from the committee, saying actually this is not routine screening in the community for everybody. This is, we've already picked up a patient with an abnormal test who we need to get to secondary care for a FibroScan, or we can do the FibroScan in the community, saving that secondary care appointment, travel, and lots of other things. And I think that was the light bulb moment that I took from that meeting. And after that, it softened a little bit. So that was interesting. The other thing that she brought into the room was the cost effectiveness shouldn't just be calculated on cost per test. It is about the picking up of patients and avoidance of other diseases, avoidance and early location of different things. Now, that can't be calculated because I don't think we have a quality metric or a calculation metric that we would be able to use within a NICE meeting for FibroScan specifically on that. So did I walk away with a general feel that NICE may well get to do something out of its normal comfort zone, but looking at the level of patients affected by poor liver health. I did personally. Whether that happens, I don't know.
It's interesting because when we're seeing people at our regular FibroScan clinics, we're not just doing the scan saying, oh, you've got a number of, it's 8 or 10 or 24 or whatever. We're also delivering a brief intervention. We're asking people about their alcohol intake, their diet. We're measuring height and weight and calculating a BMI. We're checking their blood pressure. And so all of this is more than simply just a FibroScan. So those implications go beyond the cost of simply paying for the scan, because we're having a conversation with somebody and saying to them, well, your blood pressure's on the rise now. It's, you have a body mass index over 30, you're drinking a bottle of wine a day. It may be time to start thinking about the overall effects on your health beyond that of your liver, because it's not just about liver health, it's about the wider cardiovascular picture and diabetes risks too. But as you say, it's a little bit tricky to figure out how those metrics can be captured in the way that NICE would usually review data in quite a clean mechanism.
And I think one of the best pieces of evidence was at the Nursing and Allied Health meeting at EASL, which was about the one brief intervention that a nurse had done and how it had changed somebody's diet 2 years later with FibroScan. That actually was a Spanish study, if I remember right, and it hasn't been able to be used at NICE. But their argument on that is that there's not enough evidence to say, yeah, we know brief intervention makes a difference. We know these patients engage, it makes a difference. So it's about time to write these things up. It's certainly gaining evidence and bringing it onto the BSG guidelines, for example. It's recommended to start to use some of these non-invasive technologies, ELF, iLeft, T, FibroScan, things like that, in primary care where you have access to them. So if NICE don't approve, then a number of guidelines that want access to FibroScan will still have to go through secondary care. And as you've just alluded to, there is a lot of cirrhosis coming in these backlog lists and people who need desperate help. Can we as a liver community provide a liver provided only test? I don't know. Ian?
So we've talked about quite a few issues there about the tests, the wider intervention that is the test plus a brief intervention, and then the ultimate value of those. And I'm a bit reluctant to say that FibroScan is a no-brainer. I think doing non-invasive fibrosis testing in the community in selected patients, that's a no-brainer, because that's the only way we're going to identify people who've got significant liver disease before they present, so that disease could potentially be prevented. But whether it's FibroScan or something else is still a little bit open to question, and I don't think we can FibroScan every patient in primary care, nor do I think that would be desirable. So there are a few different things to unpack, and this is part of the issue with the NICE thing, is that it's just looking at one specific part of the pathway and one specific question about where the test is best provided. That comes back to the scope of the consultation and everything else. But I think it's important just to bear in mind what NICE were asked, and then to try and understand how we use FibroScan as part of the wider pathways.
So, it's funny, in the States, it's such a different world, right? The level of rigor that you folks are living with here, in fact, rigor in the absence of data, or more to the point, the idea that absence of data is prima facie proof of lack of rigor, is not the way we usually think about things over here. Okay, now, there are a whole variety of reasons for that, and that's the reason our healthcare is ridiculously expensive and only good in places where people have money. But I'm wondering, is there a developed paradigm for how to adopt technology in places where the data is only arriving now, or do you wind up having to lag the world simply because you can't get data there fast enough on things that are good ideas?
So there are ways that the NHS can manage uncertainty in evidence with emerging technologies. And in the cancer space, they use systems called commissioning through evaluation, which is essentially a pay for the treatment, collect data and to establish its efficacy in a real-world setting. The other thing that is happening in parallel to this NICE discussion, and this parodies all of the rigour and things that Roger's just talked about, is that NHS England are currently very engaged in trying to prevent cancer. So what they're doing is they've got a sequence of community pilots to roll out FibroScan into primary care settings and also into other treatment settings like community drug services and community alcohol treatment services, to try and identify patients with significant liver disease so that those with cirrhosis can be enrolled into HCC surveillance programs, which, given the uncertainties that NICE is dealing with, it seems to have steps beyond some of the evidence that we're looking for. It's really a political decision through through NHS leadership. And I think it's really interesting to observe the differences between what's actually happening on the ground, commissioned by the central structures, against what's happening here at NICE.
So did you folks have a parliamentary election in 2012 or 2016? The reason I ask is because in that campaign, and this goes back to exactly what you just said, the expenditure on healthcare was a major issue in both the US and the UK. In the US, it was, gosh, why are we spending so much? And in the UK, it was, we're not spending enough on cancer. So if you will, literally flip sides of the issue. So I'm not surprised in the aftermath to understand that NHS may be looking at cancer in a very different, less data-rich, more politicized way than other healthcare, because A, of what cancer means metaphorically, and B, because it is a political question.
I think that's absolutely right. And the UK, its cancer outcomes aren't as good as some of its neighbours, and certainly not as good as the Scandinavian nations, and that's always been a cause for concern. And early diagnosis of cancer is one of the issues that's been at play. And I think it's really interesting that it's the liver cancer that has driven the development of these pilots for early diagnosis of liver disease, rather than early diagnosis of cirrhosis to prevent liver failure and death. And it looks like the cancer lever is a lot stronger for the sorts of reasons that you're alluding to.
So there are moments like this when Louise is in the back of my head, even though you're not speaking right now, Louise. I have one quick comment and then to you. Metaphorically, right, liver is about as far from cancer as it gets. The metaphors of liver are all, oh my gosh, you must be a drinker. Oh my God, you're eating too much. It's all about bad individual responsible behaviors, whereas except for maybe smoking-related lung cancer, we tend to treat cancer as something that fell out of the sky and dropped on our heads. And I think that's a problem all over the West. So, Louise, go ahead. But one of the things I'm scratching my head about is in a political context, what does that mean for us in terms of what we need to do to politicize liver to get to a better decision on these things?
Well, let me take the first part. I was just going to ask Ian first before I jump on that one, because, of course, it is Liver Awareness Month and Liver Cancer Month specifically. My understanding about the NHS England interest in cancer was because the ODNs were all given a FibroScan machine. So there was a FibroScan machine somewhere for the delivery of hepatitis C, and it was a reuse of that equipment. But most of the ODN scans, and the one that we got when I was in the ODN, didn't have CAP. So it's older technology and not necessarily fit for certainly NAFLD, NASH. It purely is just stiffness, which is only part of the argument. I would applaud and do applaud that initiative, but it also underlines the lack of coordination and the silos that the health service and people trying to drive wellness detection and early location we still live in. And that's a sadness for me, because I think we are linked. And to look at the politicisation, Roger, cancer is I suppose a strong lever for liver. Liver cancer is one of the fastest growing cancers globally. But if we look at the figures from this recent month that are coming out, it's the third largest cancer. It kills more people than breast cancer, but it can be linked to 40% of all, more than 40% of all cancers. So when you look at stomach cancer, when you look at all of the other cancers, breast cancer, we know that increased alcohol consumption increases your risk of breast cancer. So a lot of the other cancers can be directly related to liver. So again, we miss the elephant in the room potentially when we talk about locating other cancers. So if we then start to look at the figures, I will wait for Ian to come back on this, because I'm just generalising that if we can therefore link poor liver health to the development of cancers, it does amaze me globally that we have no public health campaign to look at people's underlying liver health, given the effect that it has on all of the other big organs, and specifically the effect of cancer. And I'm drawn to, before you jump in there, I'm drawn to Tracy Simons and colleagues' research that when you were diagnosed at 17 years of age on average with fatty liver, not cirrhosis or fibrosis, 1 in 15 was dead in 20 years of extrahepatic cancers and cardiovascular disease, to highlight that sort of data.
I can't come on the surfing the NASH tsunami wave without saying that if we're getting attention through cancer, we should just ride that wave, shouldn't we? That's the answer. Yes, we can continue to advocate for the liver failure aspects, but if we've got attention, then we should take that and run with it. The other thing that I think is important at the moment is that the liver community went to our research funder and said, we don't know what the best way to identify people at risk of liver diseases and to test them in the community. And we're asking for, well, I don't know how much people will be asking for, but they'll be asking for a substantial amount of money to fund a trial to answer some of those questions about what is the best way to diagnose liver disease early, whether that is by screening patients with risk factors, ignoring LFTs, whether it's testing LFTs and then testing downstream from there, or a blend of both approaches, which is likely to be more effective, I think, and then considering which the optimal tests are and used in what sequence. So we're actually in quite a difficult position. We're trying to ride, I don't know how many horses, but at least a couple, and that is to deliver non-invasive testing testing in the community, because NHS of England have commissioned it to try and do the best for those individuals who we can find. But at the same time, we've got to try and do research at the same time to answer questions quite similar to, but maybe not quite the same as, the questions that are coming through the NHS England pilot. I guess these are the things that happen within National Health Services, because it's coordinated. I use that term loosely because it appears as it's not completely coordinated.
So if I recall some of the things that Jeff Lazarus has talked about in the past, it's hardly coordinated anywhere in the world. That grading on a curve, this is a place where a D would get you high honors, right? Because it's not an F. And because no one's figured out how to coordinate this shit. The Indians to some degree, maybe you folks second, and after that I don't really know very much else. I could be wrong there, it's just my sense of it. Kate, any thoughts on this?
Well, I've been listening to you all chatting. What has struck me is that there's an increasing number of nurses and AHPs, certainly in the UK, who are keen to become involved in research from a perspective of identifying the questions and actually leading the studies themselves in a real clinical academic role. And you've been saying that NICE are in need of more data and more evidence. I'm just wondering what all of you think about where the opportunities might lie for more nurse and AHP-led research to focus on bringing the data that's needed to drive this forward.
I think you're absolutely right. And as a nurse with my own company, who does a lot of FibroScans within reason and more in the lifestyle, being able to look at the real-world setting for people with poor liver health who aren't patients is key for me. So, yeah, I'd love to be driving that argument. I'm trying to certainly do that. I think being able to support and deliver those mechanisms and to be able to bring in more healthcare professionals, allied health, I think is absolutely vital. I was at a meeting in Washington not so long ago, and there was a social worker who was specifically related to liver health. Now, that was a fantastic initiative. I've seen it in HIV previously, but never within liver disease itself. And I think that comes into the specifics of the BSG. The BSG quality metrics that you were part of have just literally included physiotherapists as well and dietetics, and are broadening that whole involvement in allied health in development of documents. Good evening, William.
Good evening, Will. How are you? Welcome to Surfing the Nash Tsunami.
Good evening. Thank you.
We spent the last 15 minutes trying to get Will into this podcast late, and he succeeded. Good job.
Yeah, I'm very challenged in finding my way in, so apologies. I have heard what's been talked about, though, because I was able to listen.
So normally we would ask you to spend a couple of minutes telling our other listeners a little bit about yourself and your background, but I think we'll save that for the end of the podcast for those who would like to listen to the end so we don't chop up this conversation. Will, what's your reaction to what you've been hearing? What are you thinking?
So there's a few things that sort of spark my interest. I want to wind back to your comment, Roger, about liver and cancer not occupying the same imagination for the general public. And I think the points have been touched upon. But the thing to say, Roger, is this isn't our first rodeo. We've been here before, and we've dealt with stigma before, and we've been able to work through stigma with hepatitis C. And in that sense, we did upend the way in which we deliver healthcare. We did go and find people for whom the normal model didn't work. We understood what the barriers to testing, to treatment might be. So although this is very much a metabolic disease, it's a different group of people, we're not talking about the same populations. What we are talking about, though, is marginalized people. And as liver doctors, you can't be a liver doctor, you can't be a liver nurse, physiotherapist, dietitian. You can't be a health professional in liver without really wanting to find the marginalized, without really wanting to know what it is that makes people unable to access the healthcare in the way you would want them to do it. So your question, what are we going to do about this? Well, the first is to move away from the idea of self-inflicted. Nobody wakes up in the morning and decides that they're going to have something happen to them like the alcoholic liver disease. They don't want to set out to become alcoholic. People don't set out to have diabetes, set out to have obesity, but people end up living with these conditions. Part of what the liver world has done well and needs to keep doing in this space is to make that distinction between metabolic diseases, diseases that might otherwise affect us because we don't really know what's going on in terms of our metabolism, our diet, our alcohol consumption, but then turn that around and identify the people who are at risk of significant disease. So then you talk about cancer, and cancer is a condition that people imagine just comes down upon you. Well, I don't see this as significantly different. Let's be really spiky. I've only been on the podcast for about 90 seconds. Let's be really spiky and let's let's ask the question whether or not it is the people with the same social capital who are at risk of significant liver disease as it is as the people who may be at risk of the full breadth of cancer. And in that sense, Roger, you are right. Unfortunately, cancer can happen to anyone, and bad outcomes from cancer have affected most people who are listening to this podcast, either directly or indirectly. Unfortunately, your liver disease is worse the further down the socioeconomic strata you go, and the more marginalised you are, the more likely you are to run into bad outcomes from liver disease. So they're my thoughts. I hope I haven't sort of repeated what colleagues have said.
Well, that was one of the best debuts we've had in the history of this podcast. Yeah, that was spiky. That was different. Nobody had said that, and it all makes sense. So congratulations. You might win like the initial comment bomb thrower in the entire history of the 150-something episodes we've done of this thing. That all makes sense. In fact, that all makes tremendous sense, and certainly the part about the outcomes. To the degree that liver disease is around social behaviors that you see more of, certainly, well, you see more of all those behaviors at the lower end of the socioeconomic spectrum. I guess that's right. To some degree, the marketing research I used to do at all strata and in most major industrialized countries, including the UK as well as the US, was physicians expressed frustration that the behaviors that you'd have to get wrapped around to deal with metabolic diseases, not just liver, but the whole range, were behaviors that people didn't seem capable of. Most people couldn't undertake. What is it? 10% of people can hold significant weight loss for a year, whatever the socioeconomic strata. So therefore, I think there were issues around frustration and a belief that it wasn't quite as random. Now, I think your point is right. One of the reasons it is random is socioeconomic, but when we interviewed physicians, at least, that was one of the feedbacks we got.
I don't know, Ian, Louise, Kate, I'm not sure if that's necessarily what we see. I mean, people higher up the socioeconomic stratum can consume Herculean amounts of alcohol, and I'm not sure I buy that it's better wine. I think it's actually all the other factors that we don't measure. And I think the same happens with, diet, the gourmet and the gourmand. I'm sure that the same caloric intake can happen at pretty much all socioeconomic strata, but it's the stuff that we just either we can't yet or we haven't got the infrastructure to measure. Things like how much space there is at home, how much access there is to healthy food stuffs, how much money there is to buy healthy food. If you're getting your food from a food bank, there's very little fresh food there. The number of fast food outlets between where you live and where you study or work. And I think that's not just a city or a country thing. I mean, there's 4 of us on the call who are clinicians, so what do you guys think? I mean, I'm not sure I buy that it's just the socioeconomic status because of behaviours.
I'm going to jump in before Kate gets in there. I can see her itching. I think you're right. I've got a group of guys who are very much on the higher socioeconomic scale who all drink red wine, but have changed their diet in other ways to bring down their liver fat, for example. You're right. It's about what other access people have to. But for marginalised communities, it was brought up in the recent NICE discussion about whether or not FibroScan was able to transgender that. And in fact, it was the one thing that everybody agreed on, that people who are marginalised have taken to using tests, non-invasive tests in the community. They often don't present to their primary care physicians, but they are actually interested in their liver health if you give them access. And a lot of that is through clinicians like ourselves on the front line doing outreach into these hard to reach and marginalised communities with technology. And technology is rewriting how marginalised communities can access liver care. That for me is a strength of what healthcare can bring in liver care to equity, diversity, marginalisation.
I was going to jump in and say that I'm sure all of us working clinically have looked after numerous patients who have quite senior professional jobs and unwind with alcohol because they need a quick fix in the evenings to feel slightly better after their day. And I've worked and I've looked after people with the kind of role where they take clients out for lunch and will drink a significant amount of wine at lunchtime, finish the afternoon off at work and then go home and carry on drinking again. And as you said, there are people who will justify that drinking expensive red wine is fine because it's decent quality, it's good, whereas they're not drinking the cheap cider that hasn't seen an apple, and in their minds they will justify that they're healthier and they're not like those other people because of that. But once we start breaking down the number of units per week someone's drinking and just point it out in those simple numbers, then you can often see a light bulb moment go off on the heads.
I totally get that. Well, one of the thoughts I had listening to you is that one place where social determinants of health really are clearly important, not just in diet, right, but also in exercise, which is we tell people to live healthy lives, walk more and exercise more. And one of the things that clearly does correlate with socioeconomic status is the safety of the neighborhood that you live in. So if we say to people, get exercise, and then we put them in neighborhoods that aren't safe and there are no facilities that they can easily access to go exercise, that's entirely socioeconomic. And we've put people at a a tremendous deficit.
I'm sure that safety and security are important and they do play a role. But I think even before you get there, the mum that's working 2 jobs, the dad that's going out to do shift work, and then we're lucky to have health-focused academic allied health professionals with an interest in this area who support that with evidence. I think the future is bright. I think we're a long, long way between where we want to be and where we are now. But I think we can see what that roadmap might look like.
Well, no, I think it addresses the complexity of liver health. The NICE guidance being discussed, or the medtech being discussed at the moment, is giving access to primary care, and that should actually increase this opportunity. If you look at the British Liver Trust's data from a couple of years ago, which I think has improved now, around about 74% of the country do not have access. However, when you look at where the big liver units are, if you look at Leeds, if you look at Newcastle, if you look at King's, a lot of these are in high demographic areas of poor liver disease and low socioeconomic areas, and we still have. So it's not having the big liver units in those areas with all of the technology, it's getting through the process to get to the specialists. William's right, there is a real disconnect, I suppose, and problem in getting to inequalities, and any non-invasive test, whether or not, going back to what Ian was saying, going back to whether it's FibroScan, whether or not it's ILF2, whether or not it's ELF, FIB4, has to be meaningful to get people into that pathway. But we need to take that pathway to people, because there's a lot of people do not engage with secondary care, do not want to be in a healthcare process, do not even have GPs. I've seen a lot of that come through the vaccination programme for the recent COVID. People who had never been anywhere near a GP, people who just won't engage, all high risk because of the area that I was working with in. But we now need to have NICE and other structures within NHS England. Let's take our skill to those marginalised populations, whether it's NAFLD, whether or not it's any form of living real health. That's the key, because it is a metabolic condition that shows high risks for other conditions. And again, William's right. I love him being prickly, because that was the first session I ever watched him do. I started with, I'm going to be prickly, basically. But that's exactly it. We need to be challenging those barriers. We need to be saying, you need to write things that are meaningful for the majority of people who are affected by this condition. And it's poor liver health, not necessarily liver disease at that stage.
One another thought that's just come to mind listening to the discussion is, if we do advocate that more FibroScan takes place in primary care, who will actually do the FibroScans? Because we're already hearing a lot from our primary care colleagues that more and more is pushed out to primary care and they don't have the capacity to deal with that. And a very important part of primary care is signposting for really quite serious illnesses that definitely need secondary care consultants to look after them. So who would do the FibroScans? We can certainly say that it's easy for nurses and for healthcare assistants to learn the technique. But again, there's a shortage of nurses. We have 40,000 vacancies in the UK. And when there is a significant existing clinical workload, it's quite tricky to persuade nurses and healthcare workers to take on a new role and a new clinic for something that's very, very proactive. So I don't know what everyone thinks about who would actually be the clinicians that would do the FibroScans. So
I think this has been a really interesting discussion, because it brings together all of the problems that we face, and those come all the way structurally through society to the problems in delivering what we think would be optimal healthcare for patients in a location that is close to them. And these are not easy things to address. Maybe if I could just be a little bit prickly back. So there are a few things. What we're saying is that we want to test the population, or population level risk factors: overweight, obesity, diabetes, alcohol excess. So that's about a third of the population. And then what we want to do is we want to delve really deeply and deliver bespoke interventions to those people to help them address their risk behaviours. I think that's going to be really, really challenging and probably impossible, actually, in a scalable and cost-effective way. And that, in many ways, that's what primary care is there for. Certainly in the UK, is to deliver optimal personalised healthcare to individuals based on the risk factors for all of the diseases that they might encounter, and not only liver disease. And it's logical then that this stuff is delivered in primary care. I heard a message recently from some colleagues in primary care that they're worried that they're already spending too much time testing for liver disease and not enough time focusing on the interventions that are going to help. So I think we've got a number of challenges. One is to persuade society that liver disease is important, not only through cancer. We have to show them ways that it can be made better, whether that's with public health interventions, with medicines, or with lifestyle advice. I suspect it's going to be the former, not the latter. And then we have to make testing easier so that those interventions can be delivered in a way that's meaningful to patients. So clearer messages and simplification.
So Ian, does that pull us back towards pathways and guidelines again?
Yeah, it definitely does, because it's our responsibility to make those pathways and guidelines easier. The BSG guidance that Louise mentioned is 20 pages. It's got 3 flowcharts in it, each of them applicable to different patient groups with different risk factors. And for primary care, it's too hard. We've made it look too difficult. And, I gave a talk to some other people recently and said, we have to make it look easier. We have to make it actually easier, not only look easier.
GMC Specialty goes into primary care and says, why don't you do my one test? It's terrible you don't do my one test. That is essentially a whole nother sort of set of professionals needed for the whole practice. What we're doing at the moment is we're trialling adding the FIB4 as an automated component in the diabetes annual review. Now, that's not talking about all the risk groups that you've mentioned there, Ian, but it is the people with type 2 diabetes as a first pass, and the lab returns the result. And what we're now testing is whether or not patients and clinicians want us to do the second tier test in primary or secondary care. So maybe having something that is automated. The other element in all of this is making sure that patients want to know about this. So there's an awful lot of work done with the diabetologists about a decade ago. Ask you about your HbA1c. So that seems now to be blindingly obvious, and all patients will know what their latest HbA1c was. But it wasn't that long ago that you needed to have huge public messaging campaigns to tell people living with type 2 diabetes that it was okay for them to ask about their HbA1c and okay for them to expect their caregiver, whoever that might be, to know what the HbA1c is and to communicate it back to them. So I think absolutely it is probably not feasible to FibroScan everybody at the point of risk, but there are certain things that we should be able to do that can, if you like, bring the physical intervention down the funnel so that you have fewer people to do it. And Kate, as for who does do the FibroScanning, I would probably say it's who wants to do it. There will be some people for whom this is just too much, and that has to be okay. And there will be others who want to bring it into the surgery and they want to do it themselves. We see that with other things. We see that with skin surgery. We see that with echoes. We see that with ultrasound. GPs can pick and choose what it is they wish to dip a little bit deeper into.
So, Will, in the last 3 weeks, we've had this conversation about the UK, about Germany, about Canada, and about the US. With the exception of the US, the answer on FIB4 has been the liver enzyme tests aren't standardized, therefore primary care doesn't even have the data they need to do that. How do we make that happen? I assume the pilot you're talking about standardizes all that.
Yeah.
I mean, Louise, I got that right, didn't I? Isn't that where we keep landing? You're right. I mean, that seems like a pretty self-evident solution. Not a hard test to do, not a perfect test, but not a hard test to do. You just need the standard components and it computes itself.
So it is imperfect, and I think one has to take a longitudinal view of this, which is that if this becomes a thing that you just do every year, then actually if the LFTs are slightly down, slightly up one year or another, as long as you pick up the patient and at some point can do a more detailed scan, if they really are at risk, I think then that's okay. We need to remember that these patients are going to be in some form of long-term care moving forwards. So they may not need to see their liver doctor but it might be that they'll certainly be seeing one person who's going to be doing their disease review. And if primary care continues to evolve in the way it's evolving, you're going to end up with a very multi-morbidity hat on. Again, Ian, you're absolutely right. Why take all of these multiple risk factors and only focus on one cell type in one organ? So I think you're right, but I think we will be gathering lots of information about patients, or maybe patients will be gathering lots of information about themselves, and then they'll be able to see which of the end organs is being more affected in them.
So the diabetologists have got HbA1c. What are you going to ask the patients to say? What is my ALT? FIB4?
Yeah.
Liver stiffness?
So that's really good. You're absolutely right. HbA1c is linked to outcome. We know that high HbA1c, bad, low HbA1c, good. I guess what we're saying is maybe we haven't got that number yet, but certainly I would say that what we're asking is, how bad is my fatty liver? So I was talking to a group of radiologists a wee while ago, and they said to me, what can we do to help? I said, you can do one thing, you can drop one word. When they do a scan, they tell the patient it's just a bit of fatty liver. I said, if you just drop the word just, then that would do us a world of good. So you're quite right. We don't have that test yet that's perfect, but maybe we can start the conversation towards how bad is my fatty liver.
Tying both of you in there, if you look at people with hypertension, they say, what are my numbers? What's my systolic and diastolic? Now, FibroScan is not a perfect test. It is a funnel system to get to the perfect test to pick those patients. So why not? What are my numbers? What's my stiffness? What's my CAP? That tells me what my fatty liver disease is. Know your numbers, whether or not you choose to do ALT, AST. But once you're down that pathway, know your numbers, because you know whether or not you're improving or not improving. That is a highly great motivator for everybody I certainly interact with. And coming on to Kathryn's point, one of the reasons that I left the health service was to deliver exactly what you're asking. NICE couldn't use in their fatty liver degrees pathways FibroScan. There wasn't enough access to it. It is only in bespoke areas. So yes, I'm breaking the mold. I've created a specific team that just do FibroScan, because we can go and knock off thousands in the time it takes somebody to even think about it. We can do it in any location. So we are unique at the moment, but we're so unique you can't even commission FibroScan services. We're so unique that people don't know that you can have an agency FibroScan service come in and do it. We've got 30 to 40 pop-up clinics, locations that we can go into around the country, so we can provide those cheaper. So people argue about NHS or private. Actually, it is a combined system where it is always going to be at the point of care and the point of service. It is free. But actually, we've already alluded to earlier NHS England doing one thing for liver cancer and screening, not connected to what NICE are doing with driving the discussion, certainly about giving access to primary care. Because if that doesn't go through, it stays within specialist liver units. And most of the teams that I know are overwhelmed by the work that they're getting, let alone trying to carry on diagnosing. So William's right. Let the people who want to do it, because when we do it, we want to do it really well. We are CQC regulated because it has to be about quality. We're the only CQC regulated independent provider of FibroScan. I'm the only person sitting, as far as I'm aware, as an expert who's got both outside and inside NHS experience to talk about the real life community who don't want to be patients and turn around and say, well, why wouldn't I want to know that I've got liver fat? What can I do about it? Against a healthcare patient who says, oh, don't tell me I've got something else wrong. There's a total different side. William is right. Just let the people who want to do it, but make it as it is a speciality. To do it well, to do it right, and to give that brief intervention are things that are specialist skills. That it's not just a free-for-all that people can do.
So I think we're heading towards violent agreement on some of these points. But I want to go back to Louise. I think I totally agree with what you said. I want to go back to Will's other point, though, because I think it's important. And this is the one FibroScan doesn't solve. In order to make cholesterol real, they had to do two things. They had to come up with a number and a formula that was different than two standard deviations from the mean, which in this case was, the first one was if your total cholesterol is over 200, every 1% elevation in cholesterol leads to a 2% elevation in the risk of cardiovascular disease. And getting a total cholesterol number is cheap. Getting blood pressure is cheap. If you standardize, getting FIB4 is cheap, but probably, going back to Ian's question, not the number you want everybody to know. I think we're going to be hard-pressed in fatty liver to figure out a number we want everybody to know that's inexpensive to acquire. And Ian, I thought that was the point of your question. Did I get that right?
Yes, I think so. That we've got loads and loads of tests. We're still not yet agreed what the best one is. And the ones that we think are probably the best are also the most expensive and in many ways difficult to provide at scale.
Yeah, so let's go full circle to where we started, right? We started in this meeting on September 28th asking what have we learned or what is a direction worth going in terms of FibroScan community use. And we've gone around a whole bunch of really important issues that have a lot more to do with frontline patient care. And then we've got to Louise's comment about the really powerful role, used correctly, that FibroScan can play once you've identified a patient that has an issue. And back to Will's point that they don't have just a bit of fatty liver. Maybe they don't have a bit of fatty liver. They have fatty liver, whatever that means. How do we weave all that together into a single vision? Where is the fit for all the different elements of that?
It was all about biopsy, and it was unthinkable that you might go down a fatty liver biomarker discovery route without pegging it to biopsy. And you still see that now in meetings. I think increasingly we're realizing that we can do better than that, and actually what we care about are clinical outcomes. And actually we want to know whether or not the fatty liver is itself the driver of pathology, or whether it might, for some people, simply be a biomarker of bad metabolism or bad inflammation or whatever else.
We rolled past the bottom of the hour, so I think we should probably go to wrap up. If there was one thing in this system worth improving, one finite thing you could snap your fingers and 3, 6, 12 months from now was dramatically different than it is, based on everything we've talked about today, what would it be? Brave one, go first.
So I really want a simple pathway. One test tells the clinician looking after the patient, whether that's in primary care or secondary care, what that patient's risk of having a liver liver disease event is in the next 5 or 10 years. That would make me very happy, and it would simplify decision making, and it would simplify pathways a great deal.
Okay. Good. Next. Louise, you jumped in at the same time.
Well, and I was thinking of something else until Ian said that then. And I suppose it would be very similar, but I wouldn't be only related in the liver event. Poor liver health is related to more than just the liver event. So from my holistic side, any event that patient's at risk of, I would want, whether it's type 2 diabetes, whether it's cardiovascular disease, hypertension, high cholesterol, it would be to look at a test. But going back to what I was originally going to think about, it would be to actually have NICE take that leap of faith for the liver disease community and those with poor liver health, because I think we will then drive the figures of cardiovascular disease, type 2 diabetes and real data that William talks about once more people in primary care have access to it. Because the one thing I've learned by being out there is the more people know about who's affected by liver disease, the more people want to screen people. And I think a lot of the community projects have shown that exact thing.
Okay. Kate or Will?
I think I agree very much with Louise's comments about the holistic approach. And also, I'd agree that it would be good for NICE to take a leap of faith with this, because it will go some way to reducing health inequalities that are experienced across the population.
Well, I don't think I can say anything sensible after my 3 colleagues have spoken, so I'll probably best not say anything. But just for completeness, I want to echo that, you're right. I would want a better understanding of what having a fatty liver and having a bit of fibrosis actually meant, and whether or not this is a person who we need to worry about their liver, or whether actually this is a bellwether for something else that I need to worry about. So that's what I want to understand. I'd like to know. I'd like to be able to give my patient an honest answer when they say, "How bad is this really, doc?"
First of all these answers are great, and this has been a fantastic conversation. My answer, I'm going to come from the other side of the pond, where when you ask about the economics of liver disease, everybody says, oh, no one's going to pay attention to that. That's not a big ticket item compared to everything else. So what makes liver disease such a big ticket item, as Louise points out, is all the other things besides the liver that are relevant to assessment of the real cost of having a fatty liver. So I think the better job we can do of identifying liver's appropriate place in multi-metabolic life, that will be the step that will motivate, I think, the best solution in the most places. As I said, this has been a fantastic conversation. Will, thank you for joining halfway through. You certainly did spark things up a bit, and that's a good thing. Usually that's Ian's role. Ian tends to show up and spark things up. So anybody who wants to go in and throw flame along with is welcome, and then he gets to actually go on mute from time to time. Kate, this is fantastic getting to do a podcast with you. We have to come back more often when we're talking about these kinds of issues and the roles of other providers, because they're so pivotal. Louise, enjoy Portugal. Everybody else, next time we see you, we will have gone over our 100,000 podcast, and mark your calendars for November 2nd. It's going to be a heck of an episode we show up with. So with that, I'll be back in a few minutes with the business report. We'll be back next week. Thank you, everybody. This has been fantastic.
And now for the Season 3, Episode 49 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to heroes. As this war enters a new phase, it looks like it will drag on for a while. Let's just hope that everybody is as healthy as possible and the good side triumphs.
Saturday was a big day for Nash Tsunami.
As recently as this past June, Surfing the Nash Tsunami had a 6-week period in which we averaged 1,025 downloads per week. With that in mind, I'm delighted to tell you that last Saturday we achieved 1,028 downloads in a day. How did that happen, you might ask? Well, first, response to episode 48 has been quite robust. As of Monday at 5 p.m. Eastern U.S. time, which is 5 days after the episode and a day or two after the conversations, we already have over 500 downloads between the episode and conversations, which is 100 to 150 more than we usually see by this point in time. Also, on big weeks, new people find the podcast for the first time and download bunches of episodes. This week, we can identify 10 to 12 new listeners with a significant number of multiple downloads each. If you add that to the 100 to 150 extra downloads for the episode, and we wind up with a big download week. Oh, by the way, that means we're moving towards 100K faster than we predicted. We may actually hit it by the time we post this episode Wednesday night, pretty clearly by this coming weekend.
We have top listings in new countries.
Last week, Slovakia and Bulgaria. This week, Italy. Over the weekend, Surfing the Nash Tsunami landed in 10th place in Italy on the top 250 medical podcasts and 80th place in the more demanding health and fitness category. This is the first time we've ever been even in the top 25 in Italy for medicine or made the health and fitness list at all. Big improvements. Mille grazie, Italia. We also had our best showing of the year in the UK and, for the first time, found ourselves in the top 250 medicine list in the UK, France, Germany, and Italy, all on the same day, along with 11 other countries that day.
Repeat news from last week. Our 100K party will record on October 31st and drop November 2nd.
Just as reported last week, and I'll start providing details on this next week.
This week's Vault episode looks back to NICE's first meeting on FibroScan.
This week from the Vault, we are replaying Season 3, Episode 13.4, one of the conversations from our coverage of the first NICE meeting on FibroScan back in early March. This conversation explored the dynamic tension between how NICE collects and analyzes data and the best way to assess the health value of something like FibroScan, an issue that popped up again in today's podcast, so take a listen. And with that, I'm off for the week. Thanks to the crew, Jake, Magic Mike, Eric, Steve for pushing this episode out, and special thanks to Louise for recruiting participants for the podcast, organizing the contents, and recording the intros and exits of the conversation that you hear later in the week. And as always, thanks to all of you for making this such a worthwhile labor to pursue. It boggles the mind today to think that when we started out a couple of years ago, folks thought we might get 15 episodes done before we ran out of content, maybe a few hundred people a week would listen. Our average weekly download number today is at least 4 to 5 times that. And as we hit the 100K total Buzzsprout download mark, my heart is full of gratitude to all of you who listen. Okay, so with that, we're still working on a topic for this coming Monday. It turns out there's a Wilton Park meeting that's taking a whole bunch of our surfers, including Jorn, for a second straight week, so we have to come up with something different. We will. Until then, stay safe, surf on, have a great weekend. We'll see you on the podcast again next week. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.